Good evening, friends. My name is Agnihotri. I'm Vice Chairman of the Board of IACA, as well as member of Core Committee of Festival of India and Chair of Seminars Committee. It is our honor today to kick off our seminar sessions with Dr. Nalini Saligram and Dr. K.M. Venkat Narayan. FOI, this is our 25th year, Silver Jubilee for Festival of India, and we are very delighted to have this session. Times are not that great in terms of COVID-19, etc. So we thought that this is the most topical seminar to start our program. With this, I would like to make a brief introduction of Nalini ji as well as Venkat. First of all, thank you on behalf of IACA for joining us today. And Dr. Nalini Saligram is a Ph.D. and founder of Arogya World. She has been working mostly in Chicago area and recently has moved from Chicago to Atlanta. And Dr. Narayan has been with us since actually inception, 1997. I have met Narayan, Venkat, and his wife, Asha. We have their brief bios, which I would like to share with you, so our audience know all about your good work. And I'm going to read it. Dr. Nalini Saligram is founder and CEO of Arogya World, arogyaworld.org, a global health non-profit committed to helping people lead healthier lives by preventing non-communicable diseases, NCDs, through health, education, and lifestyle change, mostly in India. She is an Ashoka Fellow, a tireless advocate for NCD prevention. Nalini leverages public-private partnerships and global platforms to improve the world we live in. She led Arogya World to make and fulfill multiple commitments in Clinton Global Initiative and United Nations Every Woman, Every Child Initiative. Arogya World was a finalist for the Drucker Award for Nonprofit Innovation in 2014, and the Arogya approach was highlighted in a book, The Healthcare Game Changers 2019. Welcome, Nalini ji.
Thank you.
Dr. K.M. Venkat Narayan is a professor of global health and epidemiology, Ruth and O.C. Hubert Chair in Global Health at Rollins School of Public Health at Emory University. Dr. Narayan is very highly qualified and educated with MD, MSc, MBA, and FRCP. He's a member of the US National Academy of Medicine and is currently Chair of Global Health, Director of Emory Global Diabetes Research Center, Director of Georgia Center for Diabetes Translation Research, and Professor of Medicine and Epidemiology at Emory University. A polymath, need for substantial multidisciplinary work in diabetes, clinical and public health sciences. He has more than 500 publications, including several seminal and high impact studies, over 177,000 citations, H-index more than 150, and 2 books. His work exemplifies his leadership in diabetes research and public health. Prior to his time at Emory, Dr. Narayan spent 10 years at the US Centers for Disease Control and Prevention, leading science efforts in his role as Chief of Diabetes Epidemiology and Statistics Branch. He was an intramural researcher at the National Institute of Diabetes and Digestive and Kidney Diseases. Welcome, Venkat.
Thank you. Thank you, Ani.
As I said earlier, that this is a very timely topic. So I would like to hand it over to you, Nalini ji, to carry forward with the seminar. And if we have any questions from audience, I will read it out to you as we proceed.
Great. Thank you very much, Annie. And thank you very much to the Festival of India for including us on this panel and for entertaining this topic, because as you said, it is really important for our times to explore India and diabetes and COVID. We're really fortunate to have someone of the caliber of Professor Venkat Narayan with us today. And I don't want to take up any more remarks. We know COVID has had an unprecedented impact on our world, and the recent second wave in India has been devastating on all counts. So let's just begin straight away with the questions and begin with COVID. So Venkat, I was just wondering, people with diabetes are said to have an greater or worse negative health outcomes from COVID. I wanted to ask you to elaborate on that and tell us a little bit more about the links between diabetes, a non-communicable disease, and COVID, a communicable one.
Thank you, Nalini. That's a very nice question. But before I answer that, I want to congratulate Festival of India for celebrating the 25th anniversary. We moved to Atlanta in September of 1996. And I still remember the first Festival of India with Ani and Chandakini led. And so it's become an institution. So congratulations, Ani. I really appreciate all the work that you all have done. So coming to your question, Nalini, what COVID has shown is two things. Number one, in terms of when you look at people developing COVID, very clearly, even those without diabetes, a high proportion of them seem to have high glucose levels when they get infected with COVID, with the virus. And secondly, the levels of glucose at the time of diagnosis seems to predict who would develop complications and who would not. So there are two major questions that have arisen. First is the COVID virus in some way either causing or bringing out diabetes? And if so, how is it doing it? Currently, there are several theories. One possibility is that it might be directly damaging the alpha and the beta cells of the islets of pancreas, which are the cells that secrete insulin and glucagon. So at a fundamental level, like the virus affects other organs, might it be also affecting the pancreas and causing diabetes or bringing out diabetes and those who are susceptible? That's one area, that's one big research question for which there's a lot of research happening currently. We don't have the answer yet. But more importantly, when we look at the people that have developed COVID and its complications, particularly hospitalization, deaths, going on to ventilation, etc., a very high proportion of them are people with diabetes. So those with diabetes who get COVID seem to do worse compared to those without diabetes. And again, this could be multiple factors involved here. One could be a socioeconomic factor, that in the neighborhoods where diabetes is common is also neighborhoods where COVID is common, and those tend to be underserved neighborhoods. That might be one explanation. The other explanation might have to do with already with diabetes, various organs are compromised. The body has faced a lot of inflammation and has had its immunity impaired. So when you have a serious infection like COVID, it multiplies and increases the risk of complications. And the third could be the combination of poorly treated diabetes and how the infection might worsen it, such as, for example, people with diabetes who develop other infections tend to do badly. So there are a number of factors. So if there is a message here, is that having diabetes, getting COVID is bad, but having diabetes and getting COVID can be really bad. So it's important both to prevent getting COVID and to keep your diabetes under control if you have diabetes, and to prevent diabetes if you don't have diabetes.
Right. Wow. So, there is a pandemic called COVID, and there is this other pandemic called diabetes, and they're both colliding. And it's really, public health today is very complex. So I have one more question about COVID for you, Venkat, and that is, this recent COVID surge in India showed a lot of, media mentions of black fungus and diabetes. And I just wanted to understand that. And I'm sure people in the audience would also be interested in hearing that from you. What is the link between black fungus?
Essentially, like I said, people with diabetes are vulnerable to all kinds of infections, bacterial and fungal infections. And what happened in the case of what's described as black fungus is people with diabetes who are poorly controlled, a high proportion of them developed black fungus, or those who received steroids inappropriately. So those were the two. And then, of course, there was a third group, which is a small group of people with immunocompromised diseases. So when you look at all the people that developed this disease, it was either they had poorly controlled diabetes, a high proportion of them, or they had steroids prescribed to them when they did not require steroids, or a small number of them had other immunocompromised diseases. once again, it brings to fore the importance of two things. If you have diabetes, get it under good control. And secondly, do not take medications that are not prescribed based on good evidence.
Right. Okay. I wanted to understand a little bit more about diabetes in India. India has been called the diabetes capital of the world. And so what is the extent of the problem, diabetes problem in India?
I mean, clearly, the three leading countries in terms of numbers of people with diabetes in the world are China, India, and the United States. These are the three most populous countries of the world. But what is very important is that the risk of diabetes in Indians is a lot higher than the risk of diabetes in your average American or your average European. So Indian people, for a number of reasons, we can go into it, are at increased risk of diabetes. So India today has a count of close to 77 million people with diabetes. That's the size of many nations. Germany, for example, it's a huge country with the number of people with diabetes, India. And this number is projected to double in the next 20 to 25 years. So it's a huge burden. And for every person with diabetes, there's probably at least two other people with pre-diabetes waiting to develop diabetes within the next 3 or 5 years. So that's another group which becomes important. But what is also striking is a high number of people developing diabetes in India are people developing at younger ages, at the most productive years of their life. And secondly, even apparently thin people, who are not obese by Indian standards, develop diabetes. So all of this makes diabetes a very serious condition for India. And as you've seen with the COVID pandemic, a large number of deaths happened in people with diabetes. The rate of deaths have been higher. And this puts right in front of the health challenges that India would face. Diabetes would be a very important one. I think India has to tackle a diabetes pandemic very well.
Right. So in our work, we've come across a couple phrases that I wanted to just bring up here. Hey, India's demographic advantage may become a demographic disaster unless something is done about diabetes and other non-communicable diseases.
I mean, it's absolutely true, because when you think about it, there are data suggesting that a family with one person with diabetes in India can spend anywhere from 25 to 40% of their monthly income on the treatment for that one person. And there are also data showing that one person in India with diabetes, particularly in lower middle income families, developing diabetes and developing kidney disease, for example, can throw the entire family into poverty. So India's economic gains and demographic dividend depends on how well she controls the health of her people, and particularly diseases like diabetes and cardiovascular disease are going to be very important to manage in their country.
Right. So, a country like India, which is already reeling from so many public health, crises, malnutrition, under 5 childhood mortality, maternal mortality, infectious diseases, also has early onset of diabetes. And if someone at age 30 gets type 2 diabetes, they've got to live 50 years more with that disease. So the public health agenda is even more crowded for countries like India. Yeah. And one stat that somebody says has stuck with me, and that is that 3 out of 4 people in metros are either diabetic or pre-diabetic. So 75% of adults in India are, have the disease or are going to get it very soon.
I mean, Nalini, I think, for example, in the 1960s, a survey in the Pima Indians of Arizona indicated that 50% of the population had diabetes before the age of 50.
Mm-hmm.
Okay? So that was dramatic news in those days.
Right.
And I worked with that population for 4 years as part of an NIH lab between 1992 and 96. But in our recent study in Chennai, the prevalence of diabetes, or the proportion of people with diabetes in Chennai in adults, is very similar to that in Pima Indians.
Right.
So you have 2 populations with very high risk. By age 55, 50% of both populations have diabetes. But the Pima Indians were about 7 BMI units heavier and 25 centimeters bigger in the waist compared to the Indians, suggesting, yes, there are huge problems for both populations, but maybe in the Indian population, there are other factors involved that we need to understand.
Right. So what about Indian Americans, Venkat? We seem to have the double whammy. We're of Indian origin and we live in the United States. So just tell me, what is the risk? What is our risk for diabetes?
This has been studied extensively. In fact, one of my students many years ago looked at all immigrants in the United States, which is about 36 million people. So she studied diabetes in all immigrant groups. And what she found was something very striking. Immigrants from the Indian subcontinent had the highest risk of diabetes compared to all immigrants, other immigrants. And the second group was immigrants from Africa. And what was also striking was that a normal weight Indian immigrant had a higher diabetes risk than an obese European immigrant. Once again, pointing out not only is the Indian American at very high risk of developing diabetes, but he or she is also at risk of developing diabetes at lower BMIs relative to their European counterparts. So that was a striking finding many, many years ago. But what is also becoming very evident is when you think about the Asian population of the United States, we are about 6% of the country, the Asian Americans, and we are part of that. But only 0.17% of NIH dollars and research goes towards this population. And that's also true in other parts. Like, for example, 90% of the burden of diabetes worldwide is in low and middle income countries like India. And yet India's contribution to global research in diabetes is less than 0.5%, whereas India contributes 17% of the burden. So there's a huge gap in our knowledge when it comes to understanding the causes of diabetes, the fundamental causes of diabetes in Indian populations, whether in Indian Americans here or in Indians in India or South Asians in general. So I think this is a gap that needs to be solved because we are finding what we study in European populations or other populations may not always apply to Indian populations. For example, some drugs have different responsiveness. Some etiological factors may be different. Indians seem to be having greater problem with the beta cells of the pancreas, and that needs to be studied properly. And then even their responsiveness to prevention seems to be somewhat different. Their diets are different, their exercise habits are different. For all of these reasons, a body of research in Indians in India and Indian Americans in the US is critically needed, and there is very little and only a few groups doing it. We need a far more attention to that area.
Right. So do we have any questions, Ani, from the audience, or should we progress? Venkat, do you have any questions?
Yeah, I mean, Nalini, your organization, Arogya, has been at the forefront of community engagement and of community education, largely in India. I want to ask you, what kind of models are you using for prevention of diabetes? Because education is important.
Right. So thank you. I founded Arogya World 11 years ago, and we work only in India, and we work only on prevention of diabetes and other non-communicable diseases through healthy living. We promote healthy living. At the core of our work is prevention, because the World Health Organization says that 80% of heart disease, 80% of diabetes, and 40% of cancers can be prevented with 3 lifestyle changes. We have to eat right, exercise, and avoid tobacco. We don't need a new vaccine. We don't need a new technology. We just have to get people to have positive health behaviors. So this whole prevention is at the core of all our work, and we work to take prevention to people right where they live and learn and work. We don't think people should go to the healthcare system, to clinics to get prevention. We take it to their doorstep. So we have programs in schools. We have programs in workplaces, and we have programs in using social media and using technology, going deep into the community. And with all of those, we have reached 5 million people to date across all our programs. we are, that's a small fraction in India of the work we have to do. And we are very conscious of that. So we look very much to show impact, and we work with people and like-minded organizations to deliver this. So our schools program, for instance, has shown 15% improvement in awareness and behavior change. And our text messaging program called M-Diabetes has shown more than 20% impact. So why is this population level prevention important? It's because of that age of onset. We have to get to the 30-year-old before they get diabetes. So we have to find where do we find large numbers of people who are 20 or 25? And the average working Indian is 25 years old. So we go to the workplace, and we are doing a lot of workplace interventions to influence the health of the working Indians. We go before that to middle school. So lifestyle habits are all set in school, in a school-going child. So we find the 11, 12, 13-year-old, and we get them to play games and activities and learn about the basic elements of healthy living. We teach them about food choices they should make, and about the importance of exercise. And we know the kids are absorbing this. So we ask them questions like, do you go out to play? How many fruits did you eat? Would you pick fruit chaat versus aloo tikki? And you know that for an 11-year-old, it's so hard to say, I won't eat aloo tikki today. So we are making headway, we are gaining traction, and we do have some evidence of this, impact across India. One other one, we use social media to teach urban women what to eat and in what quantities at every meal. So we copied the US My Plate approach and created a My Thali, which shows exact amounts of cooked food that a woman should eat, and then therefore what her husband should eat, and her son and her daughter. And we're promoting it first in urban women, and we are using social media, working with chefs and influencers to get more women committed to healthy eating. And we've also adapted it with a lot of thought leader engagement to reach rural girls, adolescent girls. That 13-year-old girl is very important, that we empower her to steer her current and future families before she gets married, before she gets pregnant and has that baby. So we are very committed to prevention and at the population level.
Yeah, it's admirable the work your organization has done, and so congratulations. And the other question for you, I know there might be a lot of people in the audience, I would imagine, who are interested in technology, being an Indian audience. Mm-hmm. So I'd like to ask you, your organization has been using technology for public good and for public health education. Can you expand on that idea a little bit?
Yeah, so many years ago, we started our text messaging program called M-Diabetes. And we wanted very much to just find a powerful and cost-effective way of reaching large numbers of Indians. And the phone is something a lot of Indians carry. It's 1 billion plus phone subscriptions, mobile phone subscriptions in India. So it's very clear that that phone is held in the hand of almost every Indian. You have vegetable sellers doing transactions on their phones. And so the phone is ubiquitous in India. And so it's also something that is in the palm of your hand, and you confront that message. You can't avoid it. So we found it to be a really powerful way of bringing about behavior change. And so we created a program called M-Diabetes. In fact, we came to Emory University, Venkat, to develop the content based on science and behavior change theory. And we have deployed that content with Nokia to 1 million Indians. So we have continued even after that. We've gone to many pockets of underserved populations within the Aravind Eye community and LV Prasad eye clinics, Lions Club, Ambuja Cement in different states. And our biggest funder on this has been Rural India Supporting Trust. We have also, and we continue to use mobile technology. In fact, we have just started looking into, tapping into artificial intelligence to improve how compelling our messages can be to persuade people to change behavior. We have also digitized our schools program at the onset of COVID. So in response to COVID, schools were closed. And because of that, our school program, which was age appropriate and compelling and game dependent to begin with, we converted it into a digital e-learning platform and are now in conversations with Maharashtra government and Goa government to take it to all school children in those states. We also use social media. So we use technology well, I would say. So for My Thali is promoted solely by social media. So we have had a reach of some 13, 14 million people. And we're trying to figure out what exactly is the meaning of that right now. So.
Nice, very nice. There's a question in the audience. Do you want to take? Shall you want me to take that first, or?
Yeah. Ani, you said.
Yes, please go ahead.
Yeah, the question is, what is your take on fasting for diabetes control? Firstly, I'll tell you what works for diabetes control or for diabetes prevention. And generally, it's a comprehensive change to one's overall lifestyle. So in terms of diet, like Nalini mentioned, we suggest, based on high level of clinical trial evidence, a diet that is rich in high fiber carbohydrates. So less of refined carbohydrates, right amount of high fiber bread or high fiber rice, brown rice. That's your staple. Lots of fruits and vegetables, generally good. Better medium of cooking oil, such as monosaturated cooking oil. Avoidance of highly saturated food, if you can manage. Fewer sweets in the diet. In fact, as little sugar as possible is always helpful. So it's that composite of diet and an adequate amount of proteins. So and plus good level of physical activity. We recommend about 30 to 45 minutes at least of walking per day, and maybe a little bit of weight training, even with dumbbells a few times a week. That really helps. Regulating your sleep. There's more and more evidence about the role of sleep and in stress reduction and diabetes management. So this composition of lifestyle works. Now, the question about extreme measures like fasting is very doubtful. I mean, on the one hand, somebody with diabetes, we would definitely not recommend fasting as an approach because it puts you at risk of developing hypoglycemia, which we don't want, which can be extremely dangerous and life-threatening. And in the area of prevention, extreme diets of fasting, intermittent fasting, etc., have been suggested. The research there is mixed so far. We don't know the things, but what we do know is an obese person who's able to shed 7% of their body weight in a fast way or in a slow way tends to have greater benefits in terms of postponing the onset to diabetes or preventing diabetes. So the short answer to your question is no for fasting, fasting for people with diabetes. For prevention of diabetes, the research is inconclusive.
So yeah, I would have to agree. So we promote a balanced meal and portion control. So if you look at our website, arogyaworld.org, the My Thali pages will show you a video. Portion and portion. Portion is nutrition and portion size. So we have, we balance that, and that is what we think is the thali that everybody should eat. Indians, we eat too much carbohydrate, too little protein, and we eat just way too much salt. So our My Thali, for instance, shows that you should have 1 teaspoon of salt in the entire day. Now that is, we Indians, we eat like 4-5 times that. And so there's a lot of education, even with stuff that is in the kitchen, that we should be doing, and we do. We are promoting just, using the ingredients in the kitchen to eat right. Don't have to do anything too drastic. So Venkat, I want to ask you a question. This is the 100th year since the discovery of insulin. And so I really just want to hear from you. What do you think? How do you think the world has tackled diabetes in the last 100 years? And how would you like to see progress happen in our lifetimes?
Yeah, great question. In fact, when I was trying to imagine reading the history of discovery of insulin, it was a moment of great excitement. Banting, who was one of the primary drivers for discovery of insulin, incidentally was an orthopedic surgeon. So that tells me that great discoveries can come from across disciplines in any mind that is curious. I mean, the basis of good science is curiosity, and that's what Banting displayed. His colleague Best was a medical student. So you're never too young or never too old for major discoveries. And the other thing was when insulin was initially isolated it was from pig pancreas. At that time, children with type 1 diabetes, the treatment for them was a question that was asked. They would be put on fasting diets to control their glucose, but invariably they would all die, or they would develop diabetic ketoacidosis. And wards in those days in Toronto and all countries, there were wards full of children with type 1 diabetes in ketoacidosis and coma, and parents sitting next to them, watching them die helplessly. So when this insulin was extracted, the researchers wanted to experiment what would happen. So they went out, injected the first child in a ward with children. And by the time they'd gone to the 7th or 8th child to inject, the first child had woken up. So this was a miracle moment. And at that time, 100 years ago, it was thought that the first major cure for diabetes had happened. But unfortunately, where we are today is two major things. Number one, the pandemic of diabetes has become huge. It's become a global problem. And even insulin, which was made very affordable by Best and Banting and the inventors, and it was sold for $1 without much patent to Eli Lilly, has become extremely expensive worldwide. Even a high proportion of people worldwide cannot afford insulin. A high proportion of people cannot afford medications. So what I would like to see in the next 10 years or 20 years is I believe that we have enough tools available today to actually find the fundamental cause of diabetes and maybe even get closer to curing it. For that, we require fundamental research, such as what we are starting to think about, understanding the beta cells of the pancreas, what damages them, what can prevent them from getting damaged, how do we replace them in the future, and better medications to manage that early processes, identifying people more early, more precision diabetes so that we don't have the one size fits all. So a lot more fundamental research. And also we keep talking about stress and how stress affects obesity. How do the brain and the pancreas talk to each other? This is another major area of research we are starting. So I think on the one hand, we need more research to understand the causes of diabetes, particularly in countries like India, Indian American populations, Asian populations, Africans, etc. And that's going to be a major, major thing that I'd like to see. But secondly, even taking all the things that we have, the interventions we have available, we have excellent data available that the lifestyle interventions that you spoke about, Nalini, can prevent 30 to 50% of diabetes or postpone the disease by 10, 15 years. Yeah. So we have to implement that in scale. And we have a lot of good drugs available for preventing diabetes and its complications. We need affordability for those kind of interventions for populations. And we need to deliver this in a way that somebody with diabetes needs to see a doctor 4 times a year, be in touch with medical care, manage their own diabetes. That implementation of good quality, high quality diabetes care needs to happen. And we have demonstrated in clinical trials that the high quality diabetes care that is practiced in a country like the United States or England can be implemented in a country like India or Pakistan at very low cost with equal benefits or even better benefits. So if I was to put it all down, I would say we need greater amount of research and data to understand diabetes, its burden, and come up with causes and cures for it. That's a separate conversation. And secondly, I would like to see the existing interventions equitably implemented at high levels of quality to all the people with diabetes in the world. And prevention of diabetes in people at high risk must happen, just like you're doing. You spoke about reaching 5 million people, but India is 1 billion people. So how do we do that?
Right. Great. Ani, it's been 35 minutes. Can we continue for a couple more or?
Yes, please. We have one more question here.
Okay, go ahead.
Yes.
Yeah, what are the negative effects of diabetes medications in the long run? I think it depends on the type of medications you're talking about. When you say diabetes medications, there are many. There is metformin, there is acarbose, there are the sulfonylureas, there's the SGLT2, there are lots of different drugs and insulin. So in general, every medication has some side effects. I mean, so the question is, what's the benefit of the medication versus the side effects of the medication? And properly delivered and under supervision, most diabetes medications, the side effects are very minimal. Mm-hmm. On the other hand, the complications of diabetes, when not treated well, is very severe. Poor glucose control can lead to blindness, kidney disease, heart attacks, strokes, amputations, and even cognitive decline and long-term dementia. And people with diabetes, a high proportion of them have high blood pressures, which requires several drugs for management. If you don't control blood pressure well, again, you put yourself at risk of heart attacks and strokes. People with diabetes have high levels of cholesterol and high levels of triglycerides. Those have to be managed by a combination of diet and combination of drugs. So overall, the question is, I think the drugs that are currently available are generally very, very safe, as long as they are well managed and properly prescribed and properly monitored. But the benefits in terms of preventing complications are huge. In fact, in many countries of the world, such high-income countries like US, UK, Singapore, the complication rates in people with diabetes have gone down because of better management. Whereas in countries like India and in low-income countries, the complication rates of diabetes are going up. So the question we need to ask is, how can we replicate the model of diabetes care from high-income countries, lower their cost, and deliver them across the population in low-income countries like India? Of course, you can go to great centers in Delhi and Chennai and Hyderabad. You will have great care, but we are talking about the masses. We're talking about 1.4 billion people.
Right. So we have one last question, so to say. What standard measures are appropriate to watch for diabetes, and how frequently should people measure? Is annual enough, or should people get their own personal machine to measure weekly or monthly?
Yeah, in general, there is a minimum standard. In general, for monitoring A1 glucose, we say get your hemoglobin A1C. And generally, we recommend at least once a year, maybe twice a year, but it depends on your physician. We recommend, getting your cholesterol measured annually, getting your blood pressure definitely measured annually, and getting your eyes examined, your feet examined, and your kidney tested. There are urine tested, etc. So all of that would be annual. But in addition to that, a big part of diabetes management is self-management. So the more educated you are as a person with diabetes, the better it is. So if you're able to monitor your own glucose, self-monitoring of glucose, it helps, and you will form your own pattern. You know what kind of foods sets you off your glucose, what brings you under control, etc. And the same thing for hypertension, if you're able to monitor it on your own. But what we recommend is don't make changes based on every single measurement. You need a pattern based on which you would need to make measurements. And increasingly, there are more sophisticated devices available, like continuous glucose monitoring and continuous blood pressure monitoring. And these we suggest for people who have more difficulty controlling their blood pressure or glucose. And and this is where, because we can look at your overall pattern of glucose over a 24-hour period, your blood pressure over a 24-hour period, and take your history of diet, your physical activity, your medication, and appropriately customize it. The field of precision medicine is advancing very rapidly, and I think it's going to get easier. And this is where good technology, good education, and good drugs will make life a lot easier.
Great. Wonderful.
Yeah. So, Ani, if I can just take one
Sure.
more minute, I want to make one point. So, anytime you talk about diabetes, you talk about screening and treatment. Okay, it's care and screening. But I really don't know what we can do to get the governments more focused on prevention. So prevention has to be equal and right up there with screening and treatment. So yes, there are powerful medicines, but for prevention, we don't need anything except eating right and exercise. And so we are very, very, I feel it's my life's mission to make prevention right up there on the radar screen of all policymakers and experts. I also want to say one more thing about the role of civil society. We are a small nonprofit. We have 14 people in India and 2 people here in the US who are part of our family. And we are able to mobilize so much, just a small group of 15, 16 people are able to reach 5 million people because we work with partners, we work with experts, we work with private sector, and we are able to mobilize so much. So the last mile, the civil society can really reach the very last mile of people. So for today, for example, I was on a call with a group that's a coalition of nonprofits. They have access to 58,000 villages in India, this network. And that's, 58 million people at least. So, if we can start thinking like that, there's a lot of fantastic development going on in India. It's very exciting. So some organizations like us can mobilize that power, work with coalitions, and take prevention as well as screening and treatment to the masses. Last point, we're also mobilizing the community in the US. So we want very much to launch a Arogya Changemakers initiative at the Festival of India. And we would love if you have people who are young professionals, in their 20s and 30s, please have them reach us. I will send you a flyer that you could please circulate. And thank you again for this opportunity and wish the Festival of India all success.
Yeah, and Nalini, if I could also add, Nalini's point about prevention is extremely important, because you can think about it like this. Glucose is essential for the brain. Without glucose, humans don't survive. Children will not survive. So glucose metabolism is finely regulated by nature. So any alteration of that homeostasis is what causes diabetes. So treatment is like after your air conditioning is broken down, you call the mechanic to fix it. Whereas you need the maintenance to make the air conditioner function all your life. So I think that's the analogy for prevention. And just like Nalini spoke about the role of civil society, as an academic, as a researcher, I too count a lot on the importance of civil society, not only in terms of spreading the message and making and creating the advocacy movement, but also in partnering with researchers and with research and with academic universities. When you see great breakthroughs and wonderful centers of excellence in the United States or in the UK, they are heavily supported by community leaders, by community, philanthropy, for community, etc. We have fantastic universities here in Atlanta. You have Emory, you have Georgia Tech, and it'll be great to leave legacies of future universities that have solved problems like diabetes for the world. And here again, I appeal to the community to partner with academia. I think it'll be it'll be a gift that never stops giving.
Great. Well, I really appreciate your thoughts and closing statements, Nalini and Venkat, and greatly appreciate what you are doing for our community and for the world, and wish you Godspeed. And we are a very small organization. We will do whatever we can do in our capacities to propagate your work, and would like to invite you for our future programs also. I would like to thank my colleagues in the seminar committee, Amit Arora, P.R. Subramanian, Rajan Gopalan, and Sanjay Goyal, who have been working with me for last 5-6 months and putting together a program, which we are going to officially start on August 15th at 12 noon, which will go up to 5 p.m. You all will get invitations, details. Times are very challenging, because of COVID situation. So, but, like Olympics, we made a commitment and we are going forward and we are doing our best that all possible precautions for COVID preparedness are being maintained. And I invite all of you to join us on August 15th in Gas South district, what they call it, used to be Gwinnett Civic Center or Infinity Civic Center, etc. So once again, thank you, Nalini and Venkat. Wish you all good evening and all the best. With
Thank you very much.
Thank you, permission to close this session.
Bye-bye.
Thank you.
Thank you very much. Bye now.
Thank you, Nalini.